Welcome back, students. We're going to be looking at a concept known as the volume of distribution. The apparent volume of distribution estimates the extent of the distribution of drug in the body, i.e. fluids or tissues. V, or volume of distribution, is a useful indicator of the type of pattern that characterizes a particular drug. So drugs with a volume of distribution of 3 to 5 liters are compatible with pattern 1 of distribution, meaning it's going to just stay in the plasma. Drugs with volume of distribution of, say, 30 to 50 liters are compatible with pattern 2. It's going to stay in the total body water. And drugs with very large values of volume of distribution are compatible with pattern 3, meaning it's going to stick to one tissue or one organ. Drugs following pattern 4 may have a volume of distribution within a wide range of values. Because of course it's varied. It may stay in one area for a little bit, then go to another area, so it's going to vary. If we know that concentration of a drug is equal to the amount of drug added to the system divided by the volume in which the drug is distributed, that relationship is what we use to determine the volume of distribution. And if you remember from the first couple of slides that speaks to the one compartment model, this is where it's coming from. Because we picture a compartment of fluid, which is the plasma, and that is where the drug is going to be distributed and dissolved and produce a particular concentration. Another way to think about the volume of distribution is that it is equal to the amount of space that a drug must fill up, such that a given dose of a drug will achieve a specific plasma concentration, just as what I was about saying. There's an assumption here, however, that is, calculation of the apparent volume of distribution presumes that the drug concentration is the same everywhere throughout the body. Now we know this is not true. It is, in all practicality and actuality, that is just not true, because most drugs are not uniformly distributed. Okay, so I want us to look a little bit more into volume of distribution, and I think that this video will open our understanding a little bit more about the concept.
So let's talk about the volume of distribution. The volume of distribution tells us how extensively drug is distributed to the rest of the body compared to the plasma. So here's any volume of water, and we can measure it in liters. And let's add any amount of drug, a drug dose, and we can measure that in mass units, usually milligrams. So once we add a specific amount of drug to a specific amount of water, we know the concentration. So now we have a concentration of drug in solution, and that's measured by the dose of the drug over the volume of the solution. This is very simple to measure. So if we take this any volume of water and measure it in liters, we can call it a compartment. And as we go through pharmacology, we will talk about various body compartments and compartment models. Let's think of this compartment as the total body, or the total body water. So when we put a drug into the single compartment, we can easily surmise the amount of drug in the total body. And that can be described as a dose over a volume, which is a concentration. Well, now let's divide the total body water into two compartments. The plasma compartment, the liquid component of blood, and the rest of the body. These two compartments make up the total body compartment. The plasma compartment and the rest of the body compartment, they are not the same size. The water compartments of the total body are 0.6 liters per kilogram. Extracellular fluid is 0.2 liters per kilogram. Blood is 0.08 liters per kilogram. The plasma, 0.04 liters per kilogram. So you can see the plasma compartment is very small compared to the total body water compartment. The plasma compartment of a 70 kilogram person is about 3 liters, whereas the total body water compartment is 42 liters. Well, it would be very simple if a drug was added to the total body and distributed evenly between the plasma compartment and the rest of the body, but that is not the case. So rarely is a drug evenly distributed between the plasma compartment and the rest of the body water compartment. Some drugs will remain mostly in the plasma and not be distributed to the rest of the body. But some drugs are extensively distributed to other parts of the body. So again, volume of distribution tells us how extensively drug is distributed to the rest of the body compared to the plasma. The volume of distribution is defined by the ratio of the amount of drug in total body to the concentration of drug in plasma. So the volume of distribution is equal to the amount of drug in body divided by the plasma concentration. And we can abbreviate that. V is equal to A over C. So if a dose of 50 milligrams of drug A results in a plasma concentration of 0.1 milligrams per liter, and we plug that into our equation, that means the volume of distribution is equal to 50 milligrams over 0.1 milligrams per liter. So, if a 50 milligram dose of drug A results in a plasma concentration of 0.1 milligrams per liter, the volume of distribution for drug A is 500 liters. Well, how is it that the volume of distribution for drug A is far greater than any actual compartment volume? Our total body water is 42 liters, so how is it that we have a volume of distribution of 500 liters? Well, that means drug A is extensively distributed to other parts of the body. In this situation, it is due to extensive tissue binding of drug A in the rest of the body. So if we add 50 milligrams of drug A, resulting in a plasma concentration of 0.1 milligrams per liter, conceptually, this is the same thing as adding 50 milligrams of drug to a single compartment of 500 liters. So the volume of distribution tells us how extensively drug is distributed to the rest of the body compared to the plasma. So the volume of distribution abstractly describes this in terms of the plasma as a single lone compartment. The volume of distribution is not an actual volume, and it may be much, much, much higher than any real body volume. But because it's based on easily measured parameter, volume of distribution is an essential component of many of the pharmacotherapeutic equations that many of you going into the professional pharmacology business will need to be able to understand. So again, the volume of distribution is equal to the amount of drug in body divided by the plasma concentration, and we abbreviate that V is equal to A over C.
Volume of distribution, or apparent volume of distribution, is calculated from measurements of the total concentration of drug in the blood compartment after a single IV injection, just as was explained in the video a while ago. VD does not represent a real volume, but rather indicates the size of the pool of body fluids that would be required if the drug were distributed equally throughout the body. It's just giving you an extent to which a drug is going to be distributed. If binding to plasma protein is high, most of the drug will be maintained within the intravascular compartment and VD will be small. If there is extravascular binding or storage in fat or other tissues, then VD will be large. So it simply means that if my VD is large, it means that the drug is going to be extensively distributed away from the plasma. So you're really looking at how extensively is the drug distributed in comparison to it being in the plasma. So if it's in the plasma, the VD is going to be small because it's going to be in the blood. And if it's going to be large, it means it's going to be extensively in other tissues away from plasma. So he went through all of that a while ago in terms of the 50 milligrams that you inject and what happens when the drug is highly protein bound, extensively distributed, VD is going to be larger. If the drug is bounded to the plasma or extensively distributed within blood, then your VD is going to be small. Thus, the VD is a characteristic property of the drug rather than the patient, although disease states may influence the VD. If there is extravascular binding or storage in fat or other tissues, VD will be large. For example, digoxin. We all know digoxin is used for heart disease, right? It is a hydrophobic drug which distributes into fat and muscle and has a VD of 640 liters. It's even more than the 500 liters that the gentleman spoke of. And this is found in a 70 kilogram man, approximately 9 times the total volume of the man. The usefulness of volume of distribution will become more apparent when we discuss pharmacokinetics and perform calculations of blood levels of drugs, which we won't do here, but you'll do in your next semester, in semester 2 with Dr. Williams, when you will be looking at pharmacokinetics. Okay, in general, acidic drugs bind to plasma protein, generally speaking, not all the time, but generally speaking. And if it's going to bind to plasma protein, we're expecting that they should have small VDs, while basic drugs tend to bind more extensively in extravascular sites, that mean away from plasma, and would tend to have larger VDs. The volume of distribution may be influenced by disease states. For example, patients with chronic liver disease have lower serum albumin concentration. Plasma protein binding will then therefore be reduced, leading to lower plasma drug concentration, resulting in higher VD. So if you are not producing the serum albumin and the plasma protein binding is reduced, it means then that the drug is now free. Remember, when the drugs are bound to protein, they form a complex and they're not going anywhere. But if you do not produce the albumin because you have liver disease or whatever the case may be that is going to reduce that protein production, it simply means that the drug is now free to distribute to other areas, the extravascular sites, and that is going to increase your VD. In other words, a drug that easily distributes into tissues of the body will have a lower concentration in the blood, and the VD will be high as a result. Conversely, if the drug tends to remain in the blood and do not distribute easily to the tissues, they will have a higher concentration in the blood and a lower VD. So as the amount of drug in the cell compartment or the tissues increases, the VD in the fluid compartment increases. This is so because extensive cellular drug binding pulls drug molecules out of the fluid compartment, aka the plasma, decreasing concentration there, thus increasing VD. Again, volume of distribution is amount of drug added to the system divided by the concentration of the drug in plasma. Okay, we have a 70 kilogram man here. Drugs that have relatively small VD, example, a volume of distribution of say 5 liters, largely stays in the plasma compartment. Drugs with a VD of 15 liters distribute throughout vascular and extravascular fluid compartments, right? So it's in the plasma as well as some areas in the extravascular sites. Drugs with VD greater than 40 liters distribute throughout the body tissues, example, vascular, extravascular, intracellular fluid compartments. Drugs with very large VD, like the 500 and the 640 liters, will need to be administered in larger doses to achieve a target concentration in the plasma. And I spoke to this already with regards to persons who are obese. They are going to need a higher dose of drug, especially if that drug, particularly if that drug is going to be distributed extravascularly, right, outside of plasma. It means that the drugs are going to be held either on protein surfaces, or it's going to be held in adipose tissues, and the drug is not going to be free to carry out its therapeutic effect, right? Remember, the drug has to be moving in order to go to its target site in order to effect a therapeutic response. So persons who tend to be larger in terms of fat content will tend to have a higher VD for certain drugs that are extensively distributed. Drugs that are lipophilic have a larger VD than water-soluble drugs, enabling them to accumulate in fat. And of course, that goes without saying. If it's lipophilic, it's going to move towards the areas that are fatter, as opposed to your water-soluble drugs, which may tend to stay in the plasma than going extensively distributed. Okay. Factors affecting drug distribution are: one, the pKa of the drug, the extent of drug plasma protein binding, partition coefficient of the drug in fat, and patient factors, their gender, their age, disease states, and patient body composition. Spoke to patient body composition, spoke to disease state. If it is that your liver is not functioning properly, then it might not produce enough albumin. If the drug was binding to albumin in the first place, it will now become extensively distributed. Therefore, you're going to have concentration of drug increasing. Patient's age, 2, you have the very young may not have a mature system and therefore will not be able to produce all the proteins at a particular age. Or if the person is old or elderly, it means that their functioning organs or their organs are not functioning as well as they should be. They may have disease or pathologies that will influence distribution. Gender, of course, male, female will have different phenotypes because of their sex, so that too is going to affect volume of distribution. Okay, so we're going to look at the effect of protein binding on patterns of drug distribution. So we looked at protein binding earlier, and drug protein binding may either be reversible or irreversible. So your drug combines with the protein and form a drug protein complex. This drug protein complex is very large. Can't go through the spaces between the capillaries to go into the tissues, so it just swims around into the plasma and stays there. Now, for reversible drug protein binding, the drug binds to the protein with a weaker chemical bond, such as hydrogen bond or van der Waals forces, and the drug protein complex is large and difficult to traverse cell membranes, even capillary cell membranes. Thus, we will have restricted distribution. So if the protein is in the plasma, it's going to stay there. For irreversible drug protein binding, this is as a result of chemical activation of the drug, which allows for a strong covalent bonding of the drug to the protein sites or the macromolecules. And this accounts for certain types of drug toxicities that occur over time, such as carcinogenesis or that may occur over a short period of time. For example, hepatotoxicity. I think I'm not sure if one of the videos mentioned this, but hepatotoxicity occurs at high doses of paracetamol. If you go over to the University Hospital of the West Indies, they have a very high rate of paracetamol poisoning because the protein binding sites now become overwhelmed in the liver and causes the liver to begin to fail. And at high doses of paracetamol, hepatotoxicity occurs because of the formation of reactive metabolite intermediates that interact with the liver protein. The major plasma proteins that can interact with drugs are the albumin, the alpha-1 acid glycoprotein, and the lipoprotein. Albumin is the most abundant protein in human blood plasma at 3.5 to 5.0 grams per deciliter, and it is produced in the liver. So if you have liver disease, it will reduce the production of albumin. Albumin comprises about half of the blood serum protein, right? Alpha-1 acid glycoprotein has a normal plasma concentration between 0.04 to 0.1 gram per deciliter, which works out to be 1 to 3% of plasma protein. It is negatively charged at physiological pH and interacts mainly with basic drugs, including beta-adrenergic receptor blockers, antidepressants, neuroleptics, and local anesthetics. So you have the different types, other types of protein. We just mentioned those three ones, but you have globulins, steroid binding globulins, fibrinogen, and all of those. So you'll see the different functions of these proteins, and these proteins have the ability to bind to different drugs. Phenylbutazone is a particular drug that displaces warfarin, which leads to bleeding. Warfarin is used as a blood thinner, right? So it thins the blood, and therefore you're more prone to bleeding. This is important during the first few days of concurrent therapy before a new equilibrium is established. Any condition which decreases albumin will affect protein-bound drugs, and this is going to increase the free fraction for a given dose. So conditions such as nephrotic syndrome will increase degradation of the albumin. Cirrhosis of the liver will decrease synthesis of the albumin, and malnutrition will also decrease synthesis. And pregnancy tend to decrease albumin production as well. So the effects of drug distribution. The efficacy of drug can be compromised by high plasma protein binding, since only the unbound fraction is available for binding to the molecular target. So you have drugs that are bound to the protein. As I said before, they are locked. They can't go anywhere, they can't move, they can't interact with any receptor site. It is just there like it's in a prison. So only the fraction of the plasma drug concentration that is freely circulating, that is unbound from the protein, can penetrate cell membranes. So protein binding thus decreases the net transfer of drug across membranes. So high protein binding will mean that you are going to have less drug interacting with the receptor sites. Consequently, if you have a drug like the phenylbutazone that kicks off the warfarin from its protein binding sites, that's a challenge. And you will see that when you are giving those drugs concurrently, you have to watch out for bleeding, because this can happen until things equilibrate and everything goes back to normal. So protein binding, drug-drug interaction is important, because you can cause deleterious effects, especially if you have a drug that has been protein bound, but you have another drug that has a higher affinity for that protein. It's going to displace that drug that may have a narrow therapeutic index, such as warfarin, which will cause serious challenges. So drug plasma protein binding is generally weak and rapidly reversible. Generally weak. They are irreversible binding, but generally, thank God, they're weak and rapidly reversible. It is as if the protein-bound drug is stored in a temporary compartment. Concentration of protein in extravascular fluid, such as the cerebrospinal fluid, lymph, or synovial fluid, is often very low. However, at equilibrium, when the concentration of free drug are equal, the total drug concentration in the plasma is usually higher than that in the extravascular fluid. Thus, it is important when interpreting blood levels of a drug, the extent of protein binding must be considered. Drugs that bind to protein can be quite a lot, right? And weak acids and neutral drugs bind particularly to albumin, while basic drugs tend to bind to alpha-1 acid glycoprotein. And you have some drugs that even bind to the surfaces of the protein on the red blood cells. The effects of protein binding on drug elimination are complex. Clearance of a drug can be affected by plasma protein binding in general. It is only the unbound part of the drug. Only the free fraction can be processed by the kidneys and the liver. Once it's bound, it can't be processed. So you run the risk of having clearance reduced of that particular drug if it is highly protein bound. And for whatever reason, something takes it off from that binding site, you're going to have toxicity because the system will not be able to clear all of it at once. So the effects of plasma protein binding, as I said, is complex, and the drugs excreted only by renal glomerular filtration. Protein binding decreases the rate of elimination since only the free drug is filtered. For example, the rates of renal excretion of several tetracyclines are inversely related to their extent of plasma protein binding. So the higher the protein binding, the less is the renal excretion of these tetracyclines. Conversely, however, if the drug is eliminated by the hepatic metabolism or renal tubular secretion, plasma protein binding may promote drug elimination by increasing the rate that the drug is presented for elimination. Okay, binding to tissue protein may cause local concentration of drug. Drugs can compete for the same binding site, and thus there is a potential for drug-drug interactions. This would be a particular concern for highly protein-bound drugs that have low therapeutic index, such as warfarin. I mentioned that already. So we're looking at factors that influence protein binding. One, the drug, the physical chemical properties of the drug. Is it lipophilic? Is it unionized or ionized? Also, the concentration of the drug in the body. If the concentration of the drug in the body is high, then the chances of it being bound to protein is also high. The protein also may be a factor that influences protein binding, the amount of protein that is available. So, for example, if albumin is synthesized in the liver and you have liver issues, then the drug that would have been bound to the albumin is no longer the albumin is no longer available for it to be bound. So that can affect distribution. The quality of the physical chemical nature of synthesized protein is there any space for the drug to bind to. What type of binding is going to happen? Is it an irreversible or a reversible one? The affinity between drug and protein. That goes without saying. Drug interactions, competition for the binding sites on the protein, alteration of the protein by substances that modify the affinity of the drugs for sites on the protein. And of course, the pathophysiological condition of the patient. right? Drug protein binding is reduced in uremic patients and patients with hepatic diseases. So the disease state is going to affect the synthesis of the protein, and that in itself is going to reduce the binding sites of drug to protein. Summary. Distribution is the process of transferring a drug from the bloodstream to tissues. Organs that are well perfused, such as the liver, the kidney, the brain, receive the bulk of the drug, while the drug is slowly distributed in poorly perfused regions, such as the kidneys, fat, and other organs. Factors that affect drug absorption, example, ionization of the drug, lipophilicity, size of the drug, pH of the environment, etc., also govern the rate and extent that a drug will distribute to various tissues in the body. Additional factors will include plasma protein binding. PD is equal to the amount of space or volume of distribution is the amount of space that a drug must fill up such that a given dose of drug will achieve a specific plasma concentration. And it is a characteristic property of the drug rather than the patient, although it may be influenced by disease state. VD might have very large numbers, that is even greater than the water content of the body. It is just going to signify how extensive is the drug distributing to other areas of the body in comparison to it being in the plasma. Binding to tissue protein may cause local concentration of the drug, and the drug can compete for other binding sites, and thus there's a potential for drug-drug interaction. And this would be of particular concern for highly protein drugs that have very low therapeutic index, example, warfarin. It is very important, however, therefore, to interpret blood levels of a drug. When interpreting drug levels of a drug, the extent of protein binding must be considered.